examination of the respiratory system, like every other system, you have to start with the general physical examination and the points that are more relevant to the respiratory system. For example, in addition to the compulsory part of the general physical examination, you would like to concentrate on the clubbing, any nicotine staining, cyanosis. You would also like to look for a JVP, secondary to right heart failure, Horner syndrome, and sort of things. Then you would like to calculate the respiratory rate, and you calculate it by looking at the chest movements for 1 minute. After finishing the general physical examination relevant to the respiratory system, you go for examination of the chest. And like every other system, the same 4 things: inspection, palpation, percussion, and auscultation. The inspection of the chest is preferably done from the foot end of the bed, and you want to look at the movements of the chest wall, whether they are symmetrical or they are asymmetrical, whether there is any depression in any part of the chest, any scar mark that is visible. At the same time, you will also like to look for any deformities of the chest. For example, there is a deformity known as the pigeon chest, in which the sternum protrudes out, or sometimes there is what is known as a pectum excavatum, in which the sternum is pushed inside the chest. A very important point is to look at the AP diameter of the chest. And normally the ratio between the AP anterior-posterior diameter and the side-to-side diameter is 5:7. In case of patients with chronic obstructive airway diseases, the AP diameter, anterior-posterior diameter, increases, and it almost becomes equal to the side-to-side diameter. And that is a very important point you need to observe in cases of chronic obstructive airway diseases. You have to comment whether the patient is using his accessory muscles of respiration for the respiratory movements. Once you are done with the inspection, you come to the next stage, which is the palpation of the chest. In the palpation of the chest, there are a few points. For example, you would first of all like to look at the trachea, whether it is central or it is deviated to one side. For looking at the trachea, you use 3 fingers. The index finger and the ring finger, they are placed over the sternoclavicular joints, and with the middle finger you insert it into the paratracheal spaces to see whether the trachea is central or whether it is deviated. If it is deviated to one side, that will tell you that there is some pathological process in some part of the chest which is either pushing or pulling the trachea. Next, you look for the apex beat. The apex beat will tell you whether the mediastinum is at the normal place or it is shifted to one side. The next step is you would like to do the expansion of the chest with a tape measure. It is usually done at the level of the nipples. And you ask the patient to take a deep breath, and the expansion of the chest should be between 2 to 5 centimeters. The next step is the chest movements. And for chest movements, you spread out your fingers and grasp the chest on both sides. Now you bring the thumbs towards the midline, and you ask the patient to take a deep breath, and you look at the movement of the thumbs. The side that is affected or that is not moving, the thumbs on that side would not be properly moving. You can do it at more than one places, and you have to look at the movement of the thumbs. Vocal fremitus is one of the clinical methods which is largely becoming obsolete. But if you like to do the vocal fremitus, you use the inner border of your hand and place it over an intercostal space. You ask the patient to say 1, 2, 3 and you feel it on the two sides. 1, 2, 3 1, 2, 3 1, 2, 3 1, 2, 3 1, 2, 3 1, 2, 3 1, 2, 3 1, 2, 3 1, 2, 3. With these few points, you are finished with the palpation of the chest. The next step is obviously percussion. As in all the other systems, you have to percuss the chest, and for percussion you have to use the middle finger of the left hand and the middle finger of the right hand. The middle finger of the left hand is placed over the chest over an intercostal space, while the middle finger of the right hand is used to strike it. Few important points in percussion is that the movement at the wrist level should be very free. The other thing is that the index finger and the ring finger should be clearly off the range, so that they do not strike the chest while you are striking the middle finger. Then another common mistake is when you percuss the chest, some people leave the finger there, and this dampens out the sound that is produced by the percussion. So when you do the percussion, you start from the supraclavicular fossae, then you come to the clavicles, and clavicles should be percussed very gently because it can cause pain to the patient. Alternatively, you can put the finger over it and percuss it the way you percuss the other areas. Comparison of the two sides is very important. That is what will tell you that there is an asymmetrical change in the note. The percussion note is normally resonant. When you percuss the chest on the left side, as you come to the cardiac borders, you can shift the finger outwards. On the right side, as you come down, you will come to the liver dullness. So, when you do it on the right side, you have to do it on the left side to compare the notes on the two sides. Besides the chest, very often we forget to percuss the axilla. Whereas axilla is a very important area because all the three lobes, they are represented in this area. So percussion of the chest is also one of the axilla is also one of the important points. After percussion, you come to the auscultation, and you have to auscultate the same areas where you have percussed. For auscultation, you have to concentrate on the breath sounds. Breath sounds are normally of two types. There is a vesicular breathing, which is present over the peripheral lung fields, and there is a bronchial breathing, which is normally present over the trachea. But if it is audible over the periphery, it becomes abnormal, and it may be due to a consolidation or cavitation or collapse of the lung. The other thing you need to comment on auscultation is the added sounds, which may be in the form of a rhonchi or wheezes, or in another added sound can be the crackles. The wheezes are whistling sounds that are produced by the air passing through a constricted bronchus, while the crackles are bubbling sounds that are produced due to fibrosing alveolitis or bronchiectasis or other chest infections. Then the next step in auscultation is the vocal resonance, in which you ask the patient to say 1, 2, 3 and you compare the two sides. 1, 2, 3 1, 2, 3 1, 2, 3 1, 2, 3 And this sort of finishes the examination of the anterior side of the chest. And position of the patient is quite important. Okay. The patient should be comfortable. And the other important point is that the scapulae should be out of your field of examination. You ask the patient to crisscross the arms and put it over the shoulders so that the scapulae are moved out of the field. Now the same four principles: inspection, then palpation. The apices, they can also be palpated from the back, and you put the fingers over the apices and you peep over the shoulders to see for the movement of the fingers, and the movement of the thumbs in this case is not important. It is the up and down movement of the fingers over the apices when the patient takes a deep breath that is to be observed. The next step is the same as done anteriorly, that is, spread out the fingers and grasp the chest and bring the thumbs towards the midline and ask the patient to take a deep breath. The movement of the thumbs will tell you whether both sides of the chest are moving equally or not. The next step is that percussion, and you have to do the percussion of the apices from in front. Then you percuss the upper border of the trapezius. This percussion of the upper border of the trapezius is a vertical percussion, and below that you percuss parallel to the intercostal spaces. Remember, don't leave the axillae unpercussed. Then you go for auscultation. Where you have to comment on the breath sounds, any added sounds, and the vocal resonance. You must remember one thing, that all these steps which have been recommended, they all help you in reaching a diagnosis, and you have to add 2 and 2 together to make a diagnosis. For example, if you miss the trachea, the signs that you will find, say at a peripheral level, can be a bronchial breathing and coarse crackles with increased vocal resonance. Now this can be present in case of consolidation or collapse, but in case of collapse, the trachea will be shifted. In case of the consolidation, trachea will not be shifted. So, if you miss examining the trachea, you will end up most probably with a wrong diagnosis. So, all these steps, they should be done one by one, and that is what leads you to a correct diagnosis in case of the examination of the respiratory system. In this system, in addition to the compulsory part of general physical examination, you would like to look for clubbing, for pulmonary erythema, dupuytren's contracture, you look for jaundice, you look for a raised JVP, you look for spiral nevi over the chest, and gynecomastia in case of the males, testicular atrophy in case of the males. Once you have finished with the general physical examination of the GI tract, you would like to examine the abdomen. Before we go to the examination of the abdomen, let us have a look at the various parts of the abdomen. The various parts of the abdomen are divided on the basis of certain planes. There is a transpyloric plane, which passes over here and is midway between the supraclavicular fossa and the pubic symphysis. And then there is a lower horizontal plane that passes at the level of the anterior superior iliac spine. Besides that, you draw two perpendiculars, one from the midclavicular line to the midpoint of the inguinal ligament on this side and on this side. So now you have got 9 quadrants of the abdomen: the epigastrium, the umbilical region, the hypogastrium, the left hypochondrium, the right hypochondrium, the right lumbar region, the left lumbar region, the left iliac fossa, and the right iliac fossa. Once we have gone through the divisions of the abdomen, we follow the same principles, that is inspection, palpation, percussion, and auscultation. Inspection of the abdomen should be from the foot end of the bed, and you look for any scar marks, any dilated veins, the distension of the abdomen, or the presence of any mass in the abdomen. The examination, the inspection of the abdomen should also be from the side, where you would like to look for any visible peristalsis. Then you come to the palpation of the abdomen. For the palpation of the abdomen, it is important that while palpating the abdomen, your hand should be in a straight line. The elbow should not be bent. And whether you have to kneel or sit beside the bed, you have to examine the abdomen with a hand in a straight line. The palpation of the abdomen is composed of a light palpation and a deep palpation. Before you go for the palpation, it is always better if you ask the patient if there is any area of tenderness. Then you palpate the abdomen lightly, you skim over it, and the palpation is with the flat of the hand, with gentle movement at the level of the MP joints. If there is any area of tenderness, then you start palpating from the area which is diagonally opposite to it. After light palpation, you come to the deep palpation, in which you would like to examine the various viscera that are present in the abdomen. The liver is present in the right hypochondrium, and when it enlarges, it goes downwards towards the right iliac fossa. So you examine the liver, or you start palpating for the liver from the right iliac fossa, so that you do not miss a massively enlarged liver. The palpation is very important. It is important that the palpation should be in relation to the phases of respiration. That is, you push the hand downward and wait for the viscous to come down during inspiration and touch your fingers. So you start from the right iliac fossa, and with each phase of respiration, you go up, and the liver margin, as it comes down during inspiration, will touch your fingers. Once the liver margin has touched your fingers, you feel for the margin whether it's regular or it's irregular, whether the liver itself is smooth or it has got some nodules, or is it irregular on the surface. Once you have made out the lower margin of the liver, you percuss for the upper border of the liver, and then you make out the span of the liver in centimeters. Once you are finished with the liver, you come for the palpation of the spleen. The spleen is present in the left hypochondrium, and it has to be enlarged 3 times before it becomes palpable. So once it becomes palpable, it appears below the right costal margin. When the enlargement is still further, it moves towards the right iliac fossa instead of going to the left iliac fossa. It moves diagonally towards the umbilicus and to the right iliac fossa. So for palpation of the spleen, again you have to start from the right iliac fossa. You move with the phases of respiration and let the spleen come down and touch your fingers. If you cannot feel the spleen in this way, there are alternative methods, like you ask the patient to tilt to your side. The leg is flexed, the arm is on the side. You stabilize the costal margin with the left arm and insert your fingers below the costal margin to feel for the spleen. The only clinical method which can be done from the left side is the hooking method of the spleen, in which you come to the left side and you hook your fingers below the costal margin to feel for a palpable spleen. Sometimes a palpable spleen can be confused with a palpable left kidney, and we'll look for some points for differentiating between the two. Now you have to feel for the kidneys, and while feeling for the kidneys, there is one hand which is placed behind the lumbar region and one hand that is placed anteriorly. The hand placed anteriorly remains static, while the hand placed behind the lumbar region pushes the kidney forward, and if it is enlarged, it strikes the hand placed anteriorly. Similarly, the palpation of the kidney of the other side, you place one hand behind the lumbar region, one hand in front. The hand in front remains static, while the one that is behind pushes the kidney forwards. Now there are a few points that differentiate between an enlarged spleen and an enlarged kidney. If the spleen is palpable, you will not be able to insert your fingers below the costal margin between the spleen and the costal margin. While in case of the kidney, which is a retroperitoneal structure, you will be able to insert your fingers below the costal margin. Then a spleen, a palpable spleen, will usually have a notch, but the kidney will not have a notch. The spleen, when it enlarges, it comes towards the umbilicus and the right iliac fossa, while the kidney, when it enlarges, it goes towards the left iliac fossa. Then the spleen, when you percuss the spleen, it will be dural percussion, while the kidney, which is retroperitoneal structure, there are loops of intestine in front of it, and so when you percuss it, it may give a resonant note. So these are the few points that can differentiate between a liver, between an enlarged spleen and an enlarged kidney on the left side. Once you are, besides that, if you find a mass, obviously you will define its margin, its size, its consistency, does it move with respiration, and is it indentable or not. Once you are finished with the palpation, you go to the next step, that is percussion. Percussion of the abdomen is done like it is done in the chest, and you start from the umbilicus, from the epigastrium, come to the umbilicus. If an enlarged urinary bladder is present, a distended urinary bladder is present, you will find dullness in the hypogastrium. Once you have done it in this direction, then you do it from the middle and go to the periphery. In case the periphery is dull, you ask the patient to tilt to your side. You wait for a few seconds and you percuss again. If it has become resonant now, that means that there was fluid which shifted to the other side and it has become resonant now. You can do it on the like this on the other side as well. This is known as shifting dullness. In case you have got a very distended abdomen, you can simply look for a fluid thrill, in which you place one hand on one side and flick the abdomen on the other side. In case you feel that there is a pulsation, you ask the patient to place his hand in the midline and you do it again. In case the patient has got a very distended abdomen and you think that there is ascites, you have sometimes to modify your methods, and you have to do what is known as a dipping method, in which you use two hands and dip like this. This would displace the fluid to one side and help you palpate the viscera. Now that the percussion is over, you would like to auscultate the abdomen. You have to auscultate the abdomen for at least 3 minutes before you say that the bowel sounds are negative. Then you can look for renal bruise, and in case you have a very enlarged liver or a spleen, you can look for a rub over the liver or a spleen, which may be due to an infarct in the enlarged viscus. Once all these things are over, you would take permission for examination of the external genitalia, and you would take permission for doing a PR examination of the patient. And this sort of finishes the examination of the gastrointestinal tract.